last ones are hypercoagulable states and then platelet disorders. Pretty straightforward, shorter classes. We're talking about all this stuff. All right, so hypercoagulable state, condition in which the blood clotting system increases the risk of thrombosis, right? Specifically, VTE, talking about DVT, TVs, strokes. This has been feeding to you, right, throughout pulmonary, cardiology, ER. One thing I will point out is when you get your phase 2, your hospital sites, people are going to approach this different ways depending on their specialty, right? We talked about scrubs, like there's the internal medicine side versus surgical side. When you have like the ER, they're going to look at it as life-threatening, they're going to treat it, right? You look at hematology, they're going to get very nerdy, down to the weeds. You get a lot of this other stuff where pulmonary is going to look at it slightly different. It's the same approach, but they're just going to have kind of a, not the same approach. We're going to have the same tools, but they may have a slightly different approach of what they're looking at when they go into this stuff. And then types, it could be either hereditary or acquired, pretty straightforward. So abnormalities in coagulation are natural anticoagulation molecules identified in 50% of patients with VTE who are without obvious reasons for VTE. What are obvious reasons for VTE? Smokers, what else?
Trauma.
Told you a patient just had surgery and they've been bedridden for 3 weeks, right? Or somebody just got off a plane or they didn't move and they were pregnant, things like that. Those are their obvious reasons. Then we talk about our most prevalent examples. So if you think of it, antithrombin, protein C, protein S, are these anticoagulants? Yeah, they're like the natural anticoagulants, right? So if you think about those, if those are deficient or missing or limited or impacted in any way, that's going to impact your ability to control clotting. So those natural anticoagulants. Factor 5, where was that in the clotting cascade? Intrinsic, extrinsic, common? What? So that common pathway down, right? Where intrinsic and extrinsic come together. Then prothrombin gene, also in that down there. And then when to consider testing. So positive family history is not necessarily positive family history of VTE. It's a positive family history of some type of thrombophilia disorder, right? So if you know that both your siblings have factor 5 mutation, and maybe they need to be considered for testing. Strong family history of DVT, PE, right? They've been, multiple family members have been in the ER, been treated, but nobody's been formally diagnosed with some of these underlying conditions, maybe an indicator. First VTE before age 50, right? The younger they are, the more concerning that there's some type of genetic disposition to this. And then if they're recurring, and you've ruled out all the secondary causes and keep getting these, right? They're not unhealthy, they're not pregnant, they're not on oral contraceptives, anything like that. And then VTE in an unusual spot. So my mom got sent me a picture, this was a few years ago, and her thumb was purple. And I was like, I don't know that. It was like right now, like some weird thing right there. So she had a blood clot in her thumb. I had to get like full cardiology and hematology workup to find out she had a hole in her heart that she'd had her whole life. She was 65 and got this weird blood clot in her thumb that made her thumb turn purple. So I mean, weird spots like that, that may be a reason to work one of these patients up. Warfarin-induced skin necrosis, which we'll talk more about. You can see some pictures. It's pretty wild. And then multiple miscarriages. One specific disorder that we're going to talk about, but that's really a hallmark of that disorder. So I don't love that this says hereditary because some of these can be acquired too as well, but they typically fall into the acquired bucket. So we talked about protein C and S being those natural anticoagulants, right? So protein C inhibits factors 5 and 8. Where is that in the clotting cascade? Intrinsic, extrinsic, common. Isn't that common, right? So warfarin initially lowers protein C, increasing clotting risk. So if you don't have protein C, you can't inhibit these factors. So just as important to know that clotting cascade actually initiating is it being terminated so that we're not creating more clots or clotting longer than we should be. So warfarin washes out that protein C and the half-life. Now you have this state where there's potential for hypercoagulable because those clotting factors are still going. So clinical presentation is recurrent VTE, skin necrosis after warfarin initiation. What are other anticoagulants that we use besides warfarin? DOAX, right? What else? Heparin, right? So why are we still using warfarin, right? It has a lot of problems. You have to get patients, monitor labs, everything else.
Artificial valves?
So artificial valves is indication, but why is the real reason why warfarin is still very popular? Cheap, right? So warfarin is like $8 to $20 a month. Heparin is a few $100, and then how much are DOAX? Like low end is like $250 to $500, right? So did they talk to you guys throughout PA school about like social determinants of health? Right, so in the DoD it's not as big a concern, but there is some concern in the DoD. For your guard, reserve, or people that are going to move out or go in other places, the big concern is the easy answer may be put somebody on a DOAC, right? It doesn't require labs, it's oral, it's great, everything else like that, very expensive. Availability to it too as well. So talking about our patient population, what's the method they can reliably get and actually take and actually be able to get in their community versus what is unrealistically available to them and what's not they're going to be able to get consistently. So with this, the diagnosis is going to be functional protein C levels. We're going to stop that warfarin, switch to an alternate anticoagulant, so either heparin, DOAC most likely, and then VTE prevention in the future. So this is more associated with like high doses of warfarin, like the initial loading dose, or they didn't do a bridge with heparin on that patient, right? They just went straight to warfarin. And then how long does warfarin usually take before it's therapeutic? It's like 5 to 7 days before you get that therapeutic levels. So it'll start working immediately, but it's not going to be to therapeutic levels for 5 to 7 days, so you have to provide a bridge. So that's typically when you see this, it's with that large loading dose or no bridge with a heparin. So protein S is also a natural anticoagulant. It's not as potent as protein C. If you think of it, protein C is kind of like the main one. Protein S is like the backup or the cofactor that's kind of enforcing that one. So if you have protein S deficiency, that's going to affect your ability for protein C to do its job, which leads to more clotting. So DVT or PE in young patients, recurrent VTE, you're going to do functional protein S levels. So when we say functional protein S levels, right? So typically you're not just doing this, you have like an idea like, oh, it's functional protein S. You're going to do like a panel, which is going to have your protein C, your protein S, your antithrombin. It's going to be a panel of different things. So you're not just having a pin mark that you think it's protein C deficiency. It's going to be multiple things. And then typically with these, you want to avoid oral contraceptives. That may be a consult that you put into OB or with hematology and say, hey, this patient's been noted to have this. Is there any oral contraceptives or other contraceptives you would recommend? Like if you've learned anything from me, share liability, get names on charts. So make sure OB is included on that decision. So warfarin-induced skin necrosis. So just what we talked about a second ago, in patients with protein C or S deficiency. So warfarin, what's the antidote for warfarin?
Vitamin K.
Vitamin K, right? It's easy to remember. So warfarin blocks production of vitamin K-dependent coagulation factors. Essentially what it's saying is protein C and S have the shortest half-life. And you knock them out, those other factors can keep going and clotting. So you don't have that natural anticoagulant. So without that bridge with heparin, you're in this risk of a hypercoagulable state for a number of days. So lesions develop 3 to 10 days following initiation of warfarin. I have a picture in a second, which is pretty dramatic. But we're going to stop that warfarin, And your slide may not be exactly the same, so make sure you take note of that. Administer vitamin K and protein concentrate or FFP, right? So it should be administer vitamin K and protein C or FFP. But then you're going to switch to an alternate anticoagulant. For testing purposes, I'm going to make it very obvious. I'm not going to put like heparin and NOAC. It'll just be an alternate. You pick which one is appropriate, right? I'm not here to be a bad projector screen, but. All right, warfarin-induced skin necrosis. So, guys start to see the trends in schools, what they do. They always show you like the worst pictures, and then in real life it never is really this dramatic. Because these are always like the things like they show you genital warts and it's just like blown up cauliflower, but the patient like end-stage AIDS, immunocompromised, and it never really looks like that in real life. So we always show you these dramatic pictures. I've seen it a few times. I've never seen it quite this bad. That would be a pretty dramatic presentation. All right, antithrombin deficiency inhibits factors 2 and 10. Where are those at? Where? Common, right? 10 is where intrinsic and extrinsic come together, and 2 is further down, the thrombin. So if you don't have antithrombin, thrombin is going to go out of control and keep going, clotting. So deficiency, increased clot risk. It can be inherited or acquired. How could this be acquired? Where are your clotting factors made? Liver, right? So think about that, like drinker, right? Somebody's hepatitis. What about trauma casualty? Somebody takes a hit to the liver, and you're having to do prolonged field care, prolonged casualty care in that situation. If their liver's not functioning, is that going to affect their clotting? Yeah, because now they're not able to manufacture that stuff. So think about that when how this can be acquired versus inherited. Diagnosis is going to be an antithrombin activity assay just to see what the levels are. And then management, anticoagulation, that concentrate, antithrombin concentrate. Hopefully everybody realizes now too that like I shouldn't have to say, but all these are going to go to hematology, right? Like these aren't going to be things that you're managing in primary care. Everything that I talk about in hematology gets referred to hematology minus some of the anemias. This is the most common blood clotting disorder, mutation in factor 5. And where's that at in the clotting cascade?
Common.
Common, right? So resistant to degradation by protein C. Remember protein C and S are those natural anticoagulants. So basically, factor 5 now is just saying, I'm not going to listen to you, protein C doesn't attack me, so it keeps going. And the recurrent DVTs, PEs, often provoked by a trigger, right? So they may be asymptomatic, and this may be one of those patients where they've had a relatively easy life, and then later on, as an adult, they have their first surgery, they have pregnancy, they get in a car accident, something triggers this, and then this is when the diagnosis will be made. They have this underlying event that kind of brings this to the surface. You do genetic testing for factor 5. Anticoagulation for significant events. If they're asymptomatic and they're having none, they don't necessarily need to be on anticoagulation. But these will be the patients, if you know they have this underlying disorder, you may consult with hematology before a major surgery or procedure to make sure that there's not something you're missing or something they want to acquire, or they want to put them on anticoagulants temporarily. For thrombin gene mutation, mutation increases the prothrombin levels, promoting clot formation. Pretty straightforward. Diagnosis, genetic testing, that specific gene, and then anticoagulation based on genetic testing. I'll be honest, like pants, they're not going to get this far down and ask you these weird random ones like this. If they do, then somebody's screwing with you, I guess. But 16 years, I've never seen anything this far down on the pants. So this was the one I was specifically talking about as far as miscarriages, right? So this is an autoimmune disorder, so they create these autoantibodies against the phospholipid promote thrombosis. So these autoantibodies attach, and then they start propagating and making thrombosis. So specifically endothelial cells, platelets, monocytes, they start getting them activated, and that creates this cascade in the blood, right? And so it really leads to DVT's big thing is recurrent miscarriage. So it could be early or late loss, but less than 10 weeks gestation. So the ability for the egg to actually to attach, and then the ability for later on for dysfunction for the placenta. We're going to make the diagnosis with APL testing. You need to do these positive antibodies on 2 occasions, 12 weeks apart. So if a mother knows this is going to be that high-risk OBGYN. They're going to make the decision that maybe this person doesn't need to have kids, or that there's some other treatment available where they may be able to if they can be put on anticoagulants. But remember that this one, I want you to just remember that recurrent miscarriage if you have that patient scenario with a pregnant woman is coming in. Here's a summary chart if you like charts. So acquired, we talked about liver disease, right? So both pro and anticoagulation factors. What are the pro factors? Intraclotting factors, right? Platelets. And what are your anticoagulation factors? Protein C, protein S, right? So it's making the stuff that actually promotes clots and breaks down clots. So if you have liver disease, it's a bad day. Acquired deficiency of protein C, protein S, antithrombin, fibrolytic factors, results in relative prophylactic tendency. So, varices, portal vein thrombosis, maybe a clinical presentation. What other things would you see with chronic liver disease? What's that? Chronic liver disease, what else could we see? Jaundice, ascites, what's that? Pruritus, okay. They could also see liver enlargement too, right? Diagnosis, increased PT-INR, which means they're bleeding, decreased platelets, decreased fibrinogen. Which factor is fibrinogen? Factor 1, right? Big thing with any of these liver diseases, doesn't matter if it's anemia or any of these other ones I've talked about, is you're always going to treat the underlying liver disease, right? We can give all the medicines we want, but if the liver's failing, then we're kind of falling behind. It's 1 step forward, 2 steps back if that liver is not getting treated. Everybody remember Burko triad? You're gonna, I promise you in phase 2, you're gonna have like at least 3 or 4 different preceptors that are gonna ask you this question. We're gonna ask you the ER, general surgery, probably ortho, probably not ortho actually, they don't ask this kind of question. Ortho more so it's like, do you keep up the NFL? Can you like talk about sports? And like, if you can do that, you can be not the best student and they'll love you. Music and sports is what I run in ortho. So, you guys have seen Wells criteria multiple times now. You've seen it in pulmonary, cardiology, ER. I'm not going to ask you a good question on the test about Wells criteria, like do that, but common being common, if the patient scenario falls into virtual triad, right? So stasis, like what is an example of this? Hemostasis.
Riding an airplane.
Cross-country travel, airplane travel, bedridden patient, right? What about hypercoagulability?
Post-op.
Birth control, what else?
Pregnancy.
Pregnancy.
Factor 5 pregnancy.
Yeah. Vessel wall injury, does that need to be like a trauma, car accident?
No.
It could be surgery, right? It could be an accident, it could just be a fall, it could be they hit their leg. So when it comes to Wells criteria, I want you to understand that more so than memorize this list. I'm not going to ask you to create a score for a patient, but you should understand the underlying factors about that. Have you guys started your ultrasound for things. You guys will do the DVT ultrasounds here and be tested on them. It's pretty cool now that they have that for you guys. So endothelial injury, activation of the clotting cascade, stasis, hypercoagulability, promote clot formation, right? So some of you may have heard this story. My first day as a PA at Fort Hood, I just got credentialed and I showed up to sick call like 5 in the morning. First one came there with calf pain. Not proud of it, but I immediately, I was like, this dude's got a DVT right now. I start freaking out. I'm ordering all this stuff. I'm getting my medics, and I bring the TMC, and I'm working them up and everything. The dude's in great shape. He just ran 5 miles. But in my mind, I just hear calf pain, and it's kind of like spasmed up, and I was like, oh shit. And he was a little red because he just got done exercise. So I'm working up, and this other PA is just like, hey man, you know this is a DVT. And I was like, no, blah, blah, blah. And they're like, he's like a healthy, like 35-year-old, and he just got done running. Definitely not DVT. I was like working it up, and then finally, like I just said, I was like, yeah, this is just a calf spasm. And that was like my day one, and like all my medics just looked at me and they're like, all right, well I don't know about this guy now. So common, right? Look at the patient and look at that history. Does it match? Does it make sense? So clinical presentation, extremely painful, unilateral, usually calf swelling, erythema. What's up? Woman sign. I don't really trust that, right? Especially if I have focus. It's cool to see, but it's not really going to sway me all that much. Then we know our well score for DVT, D-dimer, right? So if they have an elevated D-dimer, does that mean they're having a DVT or a PE? No, it could be a number of things, right? But if it's not elevated, we're definitely not having one, right? Compression ultrasound is going to be our second choice. Venography, nobody really ever does. You may do that hypercoagulability workup, right? We talked about it earlier with what was the reasons for workup. So you have a young, unprovoked patient with a DVT and a negative family history, probably not going to, or you're going to do it if they have a positive family history that's unprovoked. If it's somebody older who just has that classic, like, I'm on oral contraceptives, I'm bedridden, I'm not doing this, then may not indicate for the workup. Anticoagulation is mainstay. We'll talk more about that. That is not what that first arm's leg looked like in any way. I promise you. This would be an atypical one, right? We talked about usually calf, that arm. There may be an indication for further workup just because it's atypical, because usually it is leg. This is also like 1,000-pound sisters before and after. There's a well score. All I care about is on that right side, as you know those. Right? So, you're going to see clinical practice and what we teach are not always going to match up, right? Because you have to take a national board PANTS exam. So you're going to say, well, these slides are outdated, blah, 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 because everybody uses DOACs. I got it. But when you get tested, you're going to get tested on what is like standard of care and what's available, right? So DOACs may be great in the DoD because we have a lot of money versus like inner city Detroit or somewhere like Atlanta where there's not a lot of money. So we're going to do low molecular weight heparin or unfractionated heparin. As a bridge for warfarin, typically 5 to 7 days. If we have the availability, a DOAC would be just because of convenience and decreased monitoring. How often does warfarin patients need to get monitoring? So initially, it's like once a week kind of thing, sometimes more, sometimes less, and then typically once they're stable on the medications, like every 2 to 4 weeks. I had a contractor show up in Iraq at our aid station asking for more warfarin. And I was like, wait, what's going on here? And he was like, yeah, I got started on warfarin like a few months ago after I had a DVT. And I was like, well, you're going home. I'm not dealing with this. But he was asking, he's like, I haven't had labs done in like a month or 2. I was like, shit, all right. 3 to 6 months minimum, maybe extended for unprovoked DVTs. And again, you're going to consult with hematology and let them try to drive the train for you. You can initiate the medication, but get them to give you those recommendations to share liability. Cancer associated, we prefer low molecular weight heparin. Again, cancer, And pregnancy, we prefer low molecular weight heparin. One more time. Cancer, pregnancy, we can low molecular weight heparin. That's our choice, drug of choice. And then pregnancy, no warfarin or DOACs are both contraindicated. Bridging to warfarin we talked about, right? It takes 5 days to deplete the existing vitamin K, so we don't want to run it because vitamin C and S have protein C and S have shorter half-life, so if we don't have a bridge, we're going to be in that hypercoagulable state. So heparin, low molecular weight. And then warfarin is the safest anticoagulant to administer in patients with chronic kidney disease. So, CGFR less than 30, I want you to think warfarin. PE, right? So, depending on the size is really how it's going to drive this train. So, thrombus travels to the lungs and to the systemic system, the veins, the pulmonary arteries. The vascular obstruction puts strain on what side of the heart? Right side. So you can have acute right side heart failure relatively quickly in a patient because the right side is not really designed to deal with that pressure. Then you're going to start having that ventilation perfusion mismatch, right? So blood's pumping, but tissue, oxygen is not getting there. And that classic triad, dyspnea, pleuritic chest pain. I've never seen patient coughing up blood personally, but I'm sure it happens. And then tachypnea is the most common symptom that I want you to know about. When I talk about the EKG findings, what would be the EKG findings that you see? Yeah, but what's the most common that you're likely going to see on EKG? Sinus tachycardia, right? They're going to ask you that question with the pants, but in real life, it's always sinus tachycardia, the most common. D-dimer, just like DVT, right? It's not specific, but if it's 0, then you can rule out that they're having a PE. Imaging study, CT-PA or CTA, CT angiogram, and then that VQ scan is contraindicated for pregnant women, chronic kidney disease, allergy to contrast. And then measure anticoagulation, the same as it was for DVTs, right? If you're starting warfarin, you need that heparin bridge. If they're pregnant, what kind of anticoagulant do we want to do?
Molecular heparin.
If they have cancer, right.
Open up.
TPA, unless it's like a large, massive PE, they're really not going to do that. You start getting some hemodynamic instability. I would say the ER setting, it may not be directly evident until you got a catheter in them to actually see if there is any of that. But typically, you're going to be consulting with specialists by that point. And then epileptomy, if it's very big. If you ever see these, are pretty little spider webs when they pull them out. All right, so let's take 10. That's all I have for hypercoagulables right now. Their disorders. This is a review, right? Normal range is 150 to 450. You're going to get the lab values on the test. Don't memorize it. Go for it. I don't care. But you don't need to. But key steps is those megakaryocytes, right? They start branching off these extensions, and then those fragment off, and that's what we get our platelets, right? TPO. Sorry, raise your hand. So TPO regulates platelets. What regulates RBCs?
EPO.
And who likes to use that?
Lance Armstrong specifically.
Yeah. We don't like Lance Armstrong, right? We broke Sheryl Crow's heart. We're not tolerating that, right? We don't know the yellow bracelets, too, is what I want to know. Everybody was wearing those, and then, like, as soon as it came out, everybody's like, slide this off real quick, put that in my pocket, nobody's going to see it. Right? So TPO is what regulates platelet production, synthesized primarily in the liver. Again, so think liver damage, liver injury, liver illness is going to affect their bleeding, right? So I always think about that with the liver patients. If they have the underlying, start looking out. So case in point is if you have a patient that you're like, this guy's a drinker, do their LFTs on them and then do a good physical exam, right? Look inside their mouth, look in on their arms, legs, what am I looking for? Petechiae, right? Like trying to look for, see if there's any signs of bleeding, and then they're talking to them about like their gums. Hey, when you brush your teeth, if they're raging alcoholic, they're probably not brushing their teeth, to be honest with you. But maybe they just have very good oral care. They don't take care of the rest of their body. The platelets are a crucial role in hemostasis, right? We've talked about all that good stuff. So we get that abnormal CBC, pseudo-thrombocytopenia. We talked about that. It's that laboratory artifact. So how will we clarify that to make sure, hey man, this isn't real thrombocytopenia? What would be the test? Another CBC? You can do that. Is it going to come back probably the same?
Potentially.
Yeah, so what test would we get to confirm, to rule out pseudo-thrombocytopenia versus actual thrombocytopenia?
PT?
We're going to get our blood smear, right? The smear will show us, because thrombocytopenia is right, decreased. That'll show us if they're actually clumping together. So we're going to get that secondary, get the blood smear for that abnormal CBC to rule out that it's truly pseudo-thrombocytopenia. And then we look at those defects. It's either going to be quantitative, so thrombocytopenia is too low, or thrombocytosis is too high, or qualitative, right? The platelets aren't doing what they're supposed to be doing. They're not working. They're not functioning. Then we kind of look at, again, there's quantitative and qualitative. So quantitative, reduce survival, reduce production. If I say platelets are down, RBCs are down, white blood cells are down, what would that be called? Cytopenia. What's the first thing I want you to think?
Cancer.
Cancer until proven otherwise, right? A little less concerning if it's just platelets are decreased, but still need to address it. If platelets are just decreased, what's the biggest thing risk my patient?
Bleeding.
Bleeding, right? If they start bleeding, they're not going to stop bleeding, right? Or, I mean, all bleeding stops eventually, right? Right there, you just waiting for that punchline I saw you. Reduced production, bone marrow disorders, right? We talked about that, infection, drugs that are impacting that. We've talked about von Willebrand disease, those alcoholics. All right, immune thrombocytopenia. So if I just look at that word, what do I think about that? What is it telling me? I say immune, what should you start thinking?
Immune dysfunction?
Probably an autoimmune disorder, right? And then what's thrombocytopenia?
Killing your thrombocytes.
Right, so if you break down these words, a lot of them will give you the diagnosis and kind of point you in the direction. So immune, probably most likely an autoimmune disorder, thrombocytopenia, low platelets, right? So ITP, this is where autoantibodies target the platelets and they move them to the spleen for splenic destruction. So if your spleen's working overtime, what do you risk out with that spleen? Splenomegaly, right, starts getting enlarged, and your spleen can actually get very big and store a lot of platelets, right? Primary ITP, we also consider that idiopathic, meaning we don't have an underlying cause or reason for this. It's the most common cause of ITP, but we don't just jump to that. We rule out all these secondary causes. So autoimmune, what are some tests I could look at for autoimmune lab tests? Or maybe not specific, but they'll point me in that direction. ANA, what else? What about rheumatoid factor? MA, what about ESR? Is that specific for anything? CRP? They may be elevated, right? But they're not specific, but that may be where you start looking at that. Infection, right? Hepatitis C, H. pylori, CMV. Medication, something that is triggering that underlying that you can put together like, hey, this started on this day, they started this new medication 2 weeks ago. That maybe figure out. And then hematological malignancies, which we're going to talk about in your next block, which is oncology. Oh, you hate that. Makes it more difficult to test on, right? Patient may be asymptomatic. When I told you about hematology in general, a lot of these patients have very vague, non-specific symptoms. And a lot of these conditions you're going to find incidentally when you're running a CBC for something completely different. And this may be one of those times where you talk to the patient and they're like, yeah, I do have a hard time when I cut, or I'm shaving, I cut my leg and I bleed a lot, or I brush my teeth, I bleed a lot. So little things that we may just kind of blow off, and you start adding up and explaining these abnormal lab findings. Children often have a history of receiving viral illness, right? So they had a viral illness 2 weeks ago, they got seen pediatrics urgent care, initially got better, and then they start developing these vague symptoms that may not be connecting them. The typical presentation is that cutaneous bleeding, right? So nosebleeds, mouthing, when they're brushing their teeth, GTI rash, easy bruising, plus or minus fatigue, very vague symptoms. And if you see any of these, if you start seeing platelets are down, you start seeing fever, anorexia, bone pain, what else are you thinking? I start seeing cancer, right? We start going into those B symptoms. There's the clinical presentation. So typically as the platelets go down, right? So normal range is 150 to 450. So if they're at 450, they're fine. Gets down to maybe like 350, 400, you start seeing this dry purpura. Cutaneous, just going to be their skin, that petechiae. As it continues to drop, right? So now mucous membranes, maybe we're like 100 to 250. Those aren't exact numbers, but as it starts dropping, we're going to start seeing that. So we had a dentist that actually diagnosed one of these, looking in the guy's mouth, and he remembered that being a slide in dental school. I talked to the PA, they ran a CBC, and that's what led the training. The dentist found it on an incidental dental exam on the roof of the guy's mouth. So again, you're looking at a patient's mouth, actually get in there, look up, look down, pull their cheeks apart, so you're examining everything, so you're not missing this stuff. The visceral turning is very rare. Typically they're going to have other stuff going on by the time they get to that point. QDITP, less than 3 months, think a pediatric patient following a viral illness, right? The majority of these, it's going to be self-limiting. Once that viral illness resolves, then supportive care, and this is going to resolve on its own. Persistent, this is as they get older, and then chronic, when you think adults greater than 12 months old, it's relapsing, remitting course. It may have slightly got improved, and it's going back down, or you thought you had found the underlying trigger, but it wasn't. There's another one associated with secondary causes. So this is going to be that CBC that you get, and it's just isolated thrombocytopenia. So if you see just platelets below 1,000, 100,000, I want you to think ITP. And remember those clinical findings, right? Those are going to be as your platelet counts go down. So you may not see that initially. If it's just, say, mildly decreased. But if we're seeing isolated less than 100,000, I want you to think ITP. And a peripheral smear is typically going to be normal, right? If we had pseudo-thrombocytopenia, we would order that peripheral smear to rule that out, right? That's that going to be confirmatory. And the reticulocytes count, if the reticulocyte count was elevated, what does that tell you? Bone marrow is working overtime to replace RBCs, so since this is platelets, it shouldn't be affecting the reticulocyte counts. And then bone marrow biopsy, not necessarily used for the diagnosis, it may be used more so to rule out a secondary cause or as part of the workup to figure out if there some type of leukemia or some type of other cancer going on. So this is important to understand is the monitoring, right? So discontinue offending agents as secondary causes if you can. Know when you can monitor the patients, not to normalize platelet count, right? So if you go chasing labs and trying to get them back to normal, you're going to fail. It's never a recipe for success in medicine if you're chasing labs. But no significant bleeding in platelets greater than 20,000 can be monitored. Again, no significant bleeding in platelets greater than 20 to 30,000 can be monitored. Let me say the third time. Y'all pick up what I'm putting down. Monitor and continue until platelet count is stabilized greater than 100,000. So treatment, why would we give steroids? Yeah, it's this autoimmune disorder, right? So we want to suppress that immune system so it's not creating all these antibodies and targeting itself so the platelet levels can actually go up on their own. IVIG. Splenectomy, I would say that's less common. It's more so if they're not responsive to treatment. Rituximab, anybody ever heard of this med? What kind of med is that typically used for?
For rheumatoid arthritis?
What's that?
Is it rheumatoid arthritis?
Usually used like in oncology treatments, like non-Hodgkin's lymphoma. So why would we give that medicine for this ITP? So what it's doing is it's depleting the B cells, and B cells do what? They're the ones that create all the antibodies. So if you knock down the B cells, now we don't have this autoimmune disorder where the body's able to create all the antibodies for the platelets. So then that'll allow the platelets to actually come up on their own. So that's kind of the mindset. So you're going to hear about this drug a lot more. It's pretty common in oncology treatments. Those TPO receptor agonists. Again, this is going to be hematology. This is not going to be something that primary care, but you may inherit that patient. Patients requiring intervention, if their platelets are getting below 20,000, they're increased risk for bleeding, right? So those are the ones you're going to wrap up in bubble wrap and make sure they don't do anything. But if they're below 20,000, they're going to be hospitalized. And they're most likely going to get platelet transfusions. The big thing for ITP is we want to rule out that secondary cause. We can find it. If not, it's idiopathic, and we're going to start treating accordingly. All right, HIT, heparin-induced thrombocytopenia. The key to this is 5 to 10 days after heparin exposure, and it's not dose-related. I would say not dose-related meaning it doesn't take a lot of heparin to create this, but you're more likely going to see a more pronounced presentation if they've received a significant amount of heparin. Risk for both venous and arterial thrombosis, and it persists for weeks after heparin is discontinued. So what happens is heparin is delivered to the patient. It binds with these platelet factor 4, which triggers autoimmune response and formation of antibodies. Those complexes bind to the platelets, and then two things kind of happen that lead to this. So it activates the platelets, they lead to aggregation, they start clumping together, creating clots, right? Which releases more PF4, worsening the cycle, and we get this double-edged sword where kind of two things are going on. Platelets that are identified for removal are removed by macrophages in the spleen. The ones that escape that removal are consumed in the thrombi. So you kind of have two different ways that are causing this thrombocytopenia right now. They're being depleted naturally by the macrophages in the spleen, and then they're also being consumed by the thrombi itself if they don't get identified. So this is going to be your clinical presentation and how you're going to make the diagnosis. Platelet drop greater than 50% after heparin exposure, 5 to 10 days. So you may get like a clinical presentation of a patient was initiated on heparin, and what other anticoagulant do we use heparin for a bridge? So right, so clinical presentation may be, hey, patient is currently on warfarin, they're developing these things. They were put initially on a heparin bridge for 5 to 7 days until warfarin kicked in, and then now you're seeing them, right? It's 5 to 10 days, so you may be that day 5 to 10, where now they're starting to develop these symptoms, but they're on warfarin, they're not even on heparin anymore. Like I said before, it can persist for weeks to months after heparin is discontinued. So platelet count drop greater than 50% after heparin exposure, 5 to 10 days. Necrotic skin lesions at heparin site injections, it kind of looks like that warfarin pin necrosis that I showed you. May not be dramatic. And then that thrombosis associated with thrombocytopenia. So here's your 4T score. So you don't need to know how to do your 4T score, but I do expect you guys to understand the probabilities and the total points of what that's telling you. So low 4T scores are more predictive of excluding HIT. High scores are not as great at ruling it in and saying that this is HIT, right? It's just another tool that you can throw in your toolbox. But if we're considering that, confirmatory test is PF4 heparin antibody ELISA. There's another test that's out too. But PF4 heparin antibody ELISA, or the serotonin assay, is what I want you to know. So just those 4 T-scores. Just know less than 3, low probability, greater than 6 is high probability. So, common being common, if heparin's causing it, that's what we're suspecting. We don't have to wait for the labs to come back. Go ahead and DC your heparin, and then begin them on a secondary anticoagulant. For testing purposes, I just want you to understand that you would discontinue the heparin and start a secondary. So it could be any of those that's up there. We're going to do that until the platelet count is recovered to at least 100,000. If we're going to use warfarin, once it's up to 100,000, then we can initiate the warfarin. And our goal is a INR 2 to 3. Again, why is warfarin used so much? Cheap. But what specific kind of patients is warfarin preferred in? You said it earlier. Heart valve replacements or vascular disorders, right? So those are probably like the most common. Like even if we have access to no accident insurance will cover, they'll still likely be put on warfarin if they've had some type of valve repair. Okay. So again, these are kind of things like when you take the pants or your phase 2 stuff, they're going to start making the test questions more difficult because now they've expected that you take a pharmacology, cardiology, hematology, that you're putting all this stuff together. And then they're going to stay on anticoagulation 3-6 months. If there's documented thrombosis. Without documented thrombosis, stay for 30 days. But again, they should go into hematology and let them make that decision. Thrombotic microangiopathy. This is an interesting one. So, essentially what happens is there's some injury to the small blood vessel, right? So we're talking capillaries, arterioles, and we're looking at the endothelial cells. There's something that's causing damage to them. There's some type of injury. That creates this microthrombi formation, right? So we're getting clots in the microvasculature, so the capillaries, arterioles. That starts consuming those platelets because as those platelets start to adhere to each other, on little hand fracture, starts connecting them, they start adhesing, they start consuming up and then causing hemolytic anemia, right? So the anemia is being caused by that macrovasculature that is going through the cells, or the RBCs are going through the microvasculature, they start getting mechanically destroyed, and you start getting these schistocytes, right? So that's a unique characteristic of this. You can see schistocytes in other disorders, but for this diagnosis, you need to see schistocytes on the blood smear. The 2 main types that we're going to get is the thrombotic, thrombocytopenic purpura, TTP, and that's, think TTP, I want you to think neurological findings. TTP is neurological. Pus, hemolytic urine syndrome, we're going to think pediatric patients, right? E. coli is going to be HUS. So, TTP, think more so it can happen in kids, but think adults, neurological. HUS, think pediatric patients, E. coli. That's going to affect their kidneys. So, if I said I think it's going to affect their kidneys, what kind of lab findings would I already think? Hemolytic, uremic. So what would we expect to see? What would be the kidney values? What are like common values, common labs for kidneys? BUN creatinine, right? Probably elevated because you're having kidney damage. The reason I'm saying that is you can memorize a bunch of labs on here, but if you understand the pathology of what's going on, like you can already kind of look to see like why we would expect to see some type of elevated kidney panel, right? BUN creatinine. The primary features of both, you're going to see that microangiopathic hemolytic anemia, the schistocytes on your blood smear, right? Which is evidence of that hemolytic anemia. And then thrombocytopenia, right? The platelets are being consumed in all those microvasculature thrombi. TTP is caused by deficiency of ADAMTS13 deficiency. What this one does, ADAMTS13, basically cuts the von Willebrand factors into smaller pieces so you don't have these large von Willebrand going in there and getting all the platelets attached. And that's deficient. Now you have these large unwell-bred fractures going through there and causing platelets to adhere to each other and clotting cascade to initiate. Be acquired or hereditary. It's common with hereditary. This one, again, it's that neurological confusion, headaches, seizures, speech abnormalities, paralysis, 48% of cases. Also, median age is 40-year-old females, right? So think middle-aged female having neurological conditions. You get that CBC, you're going to see thrombocytopenia, you're going to see decreased RBCs, you're going to get the blood smear, there are going to be schistocytes on there, which is showing that there is mechanical destruction of those RBCs in the microvasculature. These other vague symptoms, fatigue, weakness, malaise, which would be common, right, in any anemic patient, abdominal pain, nausea, vomiting, diarrhea, and then just like any bleeding, that bruising, the PTI purpura, right, showing that there's some type of bleeding disorder. Right, so hemolytic testing is because of that hemolytic anemia, the RBCs are being destroyed. That peripheral smear, MAHA. Then coagulation studies, PT and PTT. What did I say about DIC in the labs? Well, how do you remember that one? They're all wrong, man. It makes no sense, right? They're clotting and they're bleeding. If you look at DIC patients, the labs don't make sense. They're all wrong. This one, how you differentiate it, because labs are starting to look a little screwy in here. When you get that PT and PTT, right, those bleeding coagulopathy labs, and they are normal. And then Coombs test, what's a Coombs test doing? What does that look at? That's detecting antibodies for those RBCs, right? So Coombs test is going to be negative. Urinalysis, seeing that. What are some other causes for proteinuria, right? This will be a common, like, you're going to get urinalysis for all your patients, and half of them are going to have elevated proteins. Military. Why do they get elevated proteins?
PKI?
What's that? Maybe kidney injury, most likely not. What else? Dehydration. They didn't hydrate the night before. Increased exercise. So when I first did PA, I was getting all these like things, and I was thinking everybody was going into kidney failure. There was like 18, 19-year-olds who just they were dehydrated, being asshats, drinking, exercising too hard, taking a lot of protein, and their body just couldn't filter it out. I was ordering all these like workups and everything else, and then finally like a lab tech told me, they're like, study patients drink more water and it'll probably be better. Did that, and I was like, thank you for lab tech. And then to confirm it, we're going to get that activity assay for that one, specifically for TTP, right? Therapeutic plasma exchange is going to be the treatment that we're going to get in there. Again, so TTP, remember TPE, TTP, TPE, TTP, TPE, right? That's a pretty easy one to remember. They take care for both presumed and confirmed diagnosis. You can also replenish that 80 AMTS13 steroids necessary. Now we talked about TTP, right? That's going to have the neurological features more so in adults. Those 40-year-old females. HUS, we're going to think pediatric patients, right? Most commonly under 5 years old. So they're going to have exposure to most likely some E. coli, right? STEC, chigotoxin producing E. coli. And then about 5 to 10 days after that infection, they're going to develop HUS, right? So this is when that primary angiopathic hemolytic anemia, right? So it's causing the schistocytes in the microvasculature, whether it be arterioles or capillaries, getting destroyed. Thrombocytopenia, the platelets are being consumed by that. And then this is most likely happening in the kidneys. So if I say acute kidney injury, what lab values should you expect? Elevated what? All right, now you're getting it. So they're going to have this history of a patient got sick. Maybe they were at a water park, maybe they ate food, maybe there was contaminated water in their house. Initially gets seen, ingestion. A few days after that event or whatever they could figure out, they start getting diarrhea, abdominal pain, fever, vomiting. Progressively worsens. 2 to 3 days into it, they start getting bloody diarrhea. So We're gonna, anytime you see bloody diarrhea, we're gonna get a culture on it, stool culture, right? You get that, then it's gonna come positive for E. coli. Then, as that diarrhea improves, right, we're about 5 to 10 days now from ingestion or exposure. Some of these patients are gonna convert into HUS, majority of them are not. So we have to be at increased awareness when they get to that point. This may be an increased risk for HUS, or they may have spontaneous resolution. Typically, you're going to start seeing these other symptoms: lethargy, abdominal pain, pallor, hypertension that's not really adding up to just an E. coli illness, right? E. coli, we just think GI. They start getting these secondary, petechial rash, hematuria, blood in their stool, blood in their urine. These labs that aren't making sense, CNS involvement, start thinking HUS. It's going to have very similar labs to TCP, but with this one, again, elevated PU and creatinine, we're going to get that stool culture, we're going to get sugar toxin to that E. coli. That's how we're going to make the diagnosis. Typically, these just require hospital care, supportive care, because this is self-limited as that E. coli condition resolves. Severe cases, they may need blood transfusion or dialysis. Potentially harmful interventions, antibiotics, right? Destroy the normal flora in their gut. Anti-motility agents, right? So what are those?
Pyramide?
What's that?
Pyramide?
Pyramide, Imodium, right? We give that, we love to give that out, and then everybody stops pooping, and then they start getting all that badness. And NSAIDs. All right, so I'll make your life easy. Don't worry about von Willebrand disease in this slideshow because we've already talked about it. I don't want there to be confusion because they don't match up 100% with the previous one. So again, testing purposes, don't care about the VWD in this one. All right, we're just going to go through it quickly. All right, so we're going to finish up with acquired platelet disorders. Uremia. Toxins impair platelet function, so if I'm staring uremia, what am I thinking? What should I be thinking? What kind of disease? Chronic kidney disease or acute kidney disease? Drugs? Pretty straightforward, right? So this is one where actually you guys in primary care can catch these, right? So if you have active duty personnel that are deploying, they're recommended, what do we recommend for heart disease? Say like somebody who has known family history, they're hypertensive, 40 years old, what will we recommend daily? The aspirin, right? So what supersedes it? Is it the risk of that patient get a heart attack on deployment, the aspirin, or is the bigger risk to say you're giving them aspirin, they get wounded and then they bleed out because you can't stop bleeding? So these are kind of things you have to look at in primary care, especially in the military. You have this stuff that civilian medicine says good, but then when you look at it from a practical standpoint in the military, you're like, maybe it's not really all that good for my patient. So look at their medications and see. You also talked about what they're taking over counter, right? They may not have that in the medical records, and you may need to figure that out before they deploy. Presentation. Mucosal bleeding despite normal platelet count, right? So in this case, they have normal platelets, normal number of platelets, but they're just not functioning. They're not working correctly. Something's impeding them. We're going to get more in depth about each one of these. So uremia-associated platelet dysfunction, uremia toxin. So we're thinking chronic kidney disease or some acute kidney disease. What will we see with those?
Increased bun. Increased bun creatinine.
PU and creatinine, right? This is straightforward. I'm not trying to trick anybody, so that's why the slide is so simple and straightforward, right? Very blatant like urine toxin. So think about a chronic kidney injury or acute kidney injury, and think about the lab value that we just talked about. Mucosal bleeding, easy bruising. Diagnosis will be platelet function test. And treatment is dialysis, desmopressin. Right? Drug-induced platelet dysfunction. What do you think NSAIDs, aspirin, right? What is this one? What's the other name for that? Plavix. Can impair platelet function. That's what it's designed to do, specifically to prevent clots. But depending on our patient, it may not be ideal. Mucosal bleeding, easy bruising, platelet function test. Again, discontinuing of the offending drugs, platelet transfusion if necessary. Proliferative disorders, so clonal disorders of hematopoietic stem cells that affect platelet function. Very rare, we're not going to see this very commonly. Typically by the time you're going to get to this point, this is already in hematology. It's not getting seen by primary care. Adequate number of platelets, but abnormality from clonal proliferation. So when they were being developed or created, something happened along the way that led to this platelets not being functioning correctly, whether they're too big, too small, or wrong receptors. And then thrombosis, bleeding, depending on the specific disorder. Paradoxical bleeding risk with increased thrombocytopenia and polycythemia vera. Diagnosis, CBC, peripheral smear. Peripheral smear is going to be the most important, and then bone marrow biopsy to see is there something going on in the manufacturing site. All right, any questions? All right, so we'll do your review tomorrow. If anybody wants to stop by my office before the test on Friday, I'll